So Abhinav is again a product of SCPGI. He did his DM from SCPGI, and he is now one of the leading gastroenterologists attached to the CK Birla Hospital in Jaipur. Abhinav has been on the faculty of the previous master classes also. And I must say that whenever I request him to chip in for non-surgical, endoscopic or gastroenterological topics, he never says no to me. I don't know whether it is because I ask him, but I presume it is because of his interest in teaching still, although he is working in a corporate hospital. Welcome back, Abhinav, and thank you very much.
Thanks for the kind introduction, sir. I won't waste a second. Straightway come to the topic which is given to me: endoscopic treatment of CBD stone. Now, these are the guidelines I'll be following because these are the latest available guidelines which everybody is following, and they are good guidelines because they guide on practical aspects of CBD stone management as far as endoscopy is concerned. So, as we all know that approximately 1/5 of all symptomatic gallstone taken for cholecystectomy might be having CBD stone. It leads to complications which are deadly like cholangitis, pancreatitis. And ERCP is modality of treatment choice for the treatment of CBD stone as it is minimally invasive. But the problem is adverse event which can go up to 15% in some cases. So the kind of serious adverse event the ERCP might lead to has dictated that we should be saying no to diagnostic ERCP. And with the MRCP and EUS, almost it has been eliminated. Now, these are the old recommendation. Since we have to choose our patient very wisely, whether a patient is having CBD stone concomitant with gallstone or not. So our suspicion has to be strong on the basis of these parameters. And earlier in these guidelines, which were brought in somewhere around 2010, bilirubin and dilated CBD were being taken separately. Bilirubin more than 4 or dilated CBD more than 6 millimeter to make a suspicion of CBD stone. Other than direct evidence like stone seen on a transabdominal ultrasound or ascending cholangitis. But guidelines have subsequently been revised because these guidelines led to unnecessary ERCPs and negative ERCPs. So now guidelines are for prediction of choledocholithiasis are, other than if you see direct CBD stone on ultrasound or cross-sectional imaging, or if you're ascending cholangitis. Other than that, the area of confusion has been obviated, which is they have combined total bilirubin more than 4 and dilated CBD. So they have to be together to make a suspicion of CBD stone. And if these things are there, then we can directly proceed to ERCP. And in absence of these findings, we have to first confirm presence of CBD stone with cross-sectional imaging. So nowadays for diagnosis, ERCP, big no, we can go ahead with the endoscopic ultrasound or MRCP. As far as EUS is concerned, EUS is comparable to MRCP. As far as diagnosis CBD stone is concerned, and specifically it is more sensitive for stone more than 5 millimeter, for microliths or sludge, or for stone impacted a temple. I'll take a second. I'll take a second. Sorry for that. So for smaller stone, for microliths or sludge, or for impacted stone at ampulla, EUS is more sensitive. And then there are certain situations where we prefer EUS over MRCP, as in case of claustrophobic patient or pacemaker. But if altered anatomy is there, like gastrointestinal bypass has been made, then MRCP is preferred. Coming to my topic, ERCP. For stone removal, 90% of the simple stone can be easily removed with ERCP. There are only 10% difficult stone which cannot be removed. And when stones are there, and especially multiple or large stones are there, 25% of the patient might require subsequent ERCP procedure. But majority, more than 75% CBD can be cleared in one ERCP procedure only. Now, to diagnose CBD stone, whether we should go for ERCP or imaging. So latest ASG guideline 2019, they have clarified issue with almost certainty. If suspicion is high, that is if a CBD stone is seen on imaging, or if there is cholangitis or bilirubin more than 4 in conjunction with dilated CBD, then chances of CBD stone are very high, more than 50%, and next step would be ERCP. And in absence of this, if only abnormal LFT are there, if age is more than 55 or dilated CBD, then we have to first confirm presence of CBD stone with EUS, MRCP, or intraoperative modalities like intraoperative cholangiogram or intraoperative ultrasound. If none of the above, then directly go for polycystectomy. So for these were as far as symptomatic gallstones were concerned, but for asymptomatic also CBD stone clearance with ERCP has been recommended even in asymptomatic stone, because since we do not know the natural history of untreated CBD stones. The problem is ERCP related complication, which is more in asymptomatic cases. In symptomatic, we have seen that highest frequency of complication 15%, but in asymptomatic CBD stones, the complication rate may go up to 25%. But still, all of the guidelines, since we do not know the natural history of these asymptomatic CBD stones, so all of the guidelines, they recommend ERCP to remove the stone. But only thing we have to be careful about a complication, and these asymptomatic patients specifically have to be done by expert and at a high volume sample. Now, a specific situation like gallstone pancreatitis, whether we should do early ERCP or late ERCP, this is the meta-analysis, 7 randomized control trial, more than 750 patients. This is available in Cochrane library. So, early ERCP, mortality, local complication, and systemic complication, related risk is high. So, urgent ERCP should only be done if cholangitis is there or persistent biliary obstruction there. Otherwise, ERCP in cases of gallstone pancreatitis should be delayed for more than 48 hours till pancreas is cooled off. Sometimes in the gallstone pancreatitis, we have simple situation like stone obstructing papilla. It bulges papillary orifice, and we just have to give a nick and stone pops out. Job is now timing for ERCP. For cholangitis, as we know, that this is a dreaded complication of obstructed biliary system. So this meta-analysis studied nine studies and 7,500 patients. Emergent ERCP, that is ERCP within 48 hours versus delayed ERCP. And they saw that if ERCP is done within 48 hours, there is lower risk of organ failure, lower mortality, and shorter hospital stay. So, in cases of cholangitis, urgent ERCP within 48 hours. In presence of pancreatitis, delayed ERCP after 48 hours. So, guidelines are clear now on this. Now, what is the algorithm we routinely follow for treatment of endoscopic treatment of CBD? If a small stone are there is no stricture, then simply sphincterotomy and balloon or basket extraction. If stone is slightly bigger, then limited sphincterotomy with balloon dilatation and job is done. For large stone, dilated distal CBD, large balloon dilatation is done. For large stone, but distal CBD is smaller than a stone, then we have to resort to other modalities. Now coming to the first situation, small stone, no stricture. ERCP, sphincterotomy, balloon shift, 90% success rate. So this is the easiest subset of the patient. Even if multiple stones are there, no problem, they can be cleared one by one. And in situation where even CBD is totally jammed up, impacted, even with small sphincterotomy, all of the stone can be removed. Now, second situation, large stone with dilated CBD. Here we need to resort to large balloon dilatation since the stone is larger. So, strategies for these large stones is either we can enlarge the CBD stone either with sphincterotomy or balloon sphincteroplasty, or we can reduce the stone size by crushing, or we can combine both of the approaches. Now, liberal sphincterotomy to enlarge the opening of the CBD. The problem is this is limited by the safe portion of the papilla. Means how much portion of papilla is there in the intraduodenal wall. So if we are lucky if we get a large intraduodenal portion like this case, we can remove a bigger stone simply with liberal sphincterotomy, but we have to be cautious. Sometimes this may lead to perforation. So careful assessment of papilla is must. Second option to enlarge CBD opening is balloon sphincteroplasty. So here we can put in a balloon at the sphincter and then we can dilate. There have been studied with simply only with balloon dilatation without sphincterotomy, but it was seen that there were cases of pancreatitis, and some of those cases were fatal. So nowadays, small sphincterotomy is done, followed by balloon dilatation. What sphincterotomy does? It provides a pathway for balloon to expand, and this pathway takes the pressure away from the pancreas, so pancreatitis doesn't occur. So balloon sphincteroplasty followed by balloon dilatation, small sphincterotomy with the balloon dilatation is the way to go. Now, these are the results. Comparison of balloon sphincteroplasty versus EST and sphincterotomy alone. So balloon sphincteroplasty, if combined with EST, it leads to overall increase in clearance of CBD stone. It obvious need of mechanical lithotripsy, and it also reduces adverse event. So whenever there is a large stone, we should do small sphincterotomy with balloon sphincteroplasty rather than sphincterotomy alone, since combination is better in terms of all these parameters. Now, again, very large stone, but CBD is not strictured. This is the example how balloon sphincteroplasty is done. After small sphincterotomy, we can see that on subsequent cholangiogram, CBD is clear and stone can be removed. Even if CBD is packed with a stone, including one of few stones which are larger one, this technique helps. We can clear CBD completely.
Ground floor emergency bed number 8402.
Even gigantic stones like this can be removed using
bed number 8402.
So even larger stone like this can be removed using this technique, small sphincterotomy and large balloon sphincteroplasty. Again, we have to see that doing large balloon sphincteroplasty can sometimes lead to more of bleed and sometimes perforation risk is there. So with all these techniques, sphincteroplasty, sphincterotomy, dilatation of bile duct, should we redefine the common bile duct stone? Earlier, more than 1 centimeter stones used to be considered as a very large stone, but nowadays, utilizing these techniques, we can remove even a stone up to 2 centimeters very easily without any further and without need of any further equipments. So there is a need to redefine large stone. The problem comes when stone is large, but lower CBD is smaller than the size of the stone. In these cases, we need to go further. We need either cholangioscopy or we need mechanical lithotripsy kind of equipments. So before embarking on this, we should understand what is a difficult stone. Difficult stone can be because of characteristics of stone. It can be because of lower CBD parameters and other things. So if a stone is very large, we don't know the size. Some literature says it is more than 1.5 centimeters, some say 2, some say 3 centimeters. But in general, usually 2 to 2.5 centimeter stone is considered large one. Sometimes even a smaller stone, as small as 8 millimeter, can also be a large stone if it is large enough for lower CBD. Shape of stone is also to be taken in consideration. Certain shapes like barrel or piston shapes are difficult to remove. A very hard stone again is difficult to remove. If lower CBD is narrow, small papilla is small. If lower CBD shape is abnormal like sigmoid shape, if there is large periampullary diverticulum, then this make a stone difficult to be removed. Faceted stone, impacted stone, intrahepatic stone, and altered biliary anatomy, they lead to difficulty in stone removal. So we have to consider all these parameters before attempting biliary stone removal. See this cholangiogram, stone is quite big and lower CBD is absolutely narrow. So this stone cannot be removed without any additional procedures. Sometimes, if such a situation arises, we may just put in a stent and we come out, because putting in a stent and going subsequent occasion after 4 weeks, due to constant friction of a stent, stone becomes softer, and sometimes it may get fragmented. And second time ERCP, we might remove it very easily. Sometimes lower CBD is very narrow. Here, stone is hidden behind the endoscope. It cannot be seen. It is small stone, but lower CBD is very narrow. Wise decision to put in a stent and come out. On subsequent visits, we can see that this is a second ERCP. As we can see, a stent is there on left side of the panel. The cholangiogram shows very large gigantic stone. Biliary balloon dilatation is being done, and the stone can be removed on subsequent attempt. So the caveat is that if stone is very big, if it cannot be removed in one ERCP, so two short ERCPs are better than one long ERCP, which would, because longer the procedure do, higher the chances of perforation and higher the chances of complications. Now coming to next step, mechanical lithotripsy. So in situation where stone is very large and lower CBD is narrow, we have to resort to mechanical lithotripsy. Two varieties are available. One is through the scope lithotripters, where there is a metal sheath and basket which you can insert through the scope without need to remove the scope. And other are out of the scope lithotripters, which are available in the market. Now, success rate of these techniques is 79 to 90% after failed conventional method, which is biliary balloon sphincteroplasty for removal of large stone. Now, this is the most dreaded situation for a gastroenterologist doing intervention. You see there is a basket and no endoscope. Means basket has infected and endoscope has been removed. What to do now? Either you go for surgery or you utilize some kind of lithotripsy techniques, which is out of the scope lithotripsy. So out of the scope lithotripsy, also called rescue mechanical lithotripsy. Here we have to cut the basket which is hanging out of the scope because other end is stuck up in the CBD. We cut the basket, we remove the endoscope, and we load these wires into the coil sheath of the lithotripter metallic coil. And then we pass wire into the handle. And as we rotate the handle, it crushes the stone inside the CBD. Now, this is a short video how this mechanism works. If somebody gets stuck up with the impacted basket, they can cut the wire and they can break the stone using this lithotripter out of the scope lithotripter. The only thing you have to sacrifice your basket here. And some of the basket, they do not, sometimes the stone is very hard. So even basket breaks, but that is again okay, at least you are able to disinfect the basket. Now, this is the example of through the scope mechanical lithotripsy. You can see in lower left panel, a metal sheath is being advanced through the endoscope, and we can see the stones are being crushed and stone can be taken out using this technique. So for difficult stone, initially we would try with balloon or basket after biliary sphincteroplasty. If there is a failure, we try mechanical lithotripsy. But even if mechanical lithotripsy fails, then we have cholangioscopy guide option. So these are the options for failed mechanical lithotripsy. You can use cholangioscope. Two options are there: laser lithotripsy or electrohydrolithotripsy. There is an option of extra corporeal shockwave lithotripsy. Patient can be sent for surgery, or you can just put in a stent and do the procedure on subsequent visit. So what is the how extra corporeal shockwave lithotripsy this helps? Basically, we have to focus shock waves on calculi, and shockwave, they basically generate energy in the stone, and stone get blasted. Complete dedicated setup has to be there, and one requirement which is very essential, since all of the 90% of CBD stones are not radio opaque, there is a need to put in a nasobiliary catheter. We pass contrast to the catheter to opacify the stone, and then only we can focus the scope. We can focus the stone and break them according to shock wave. Complete clearance rate to the tune of 85%, and 2/3 of the patient, they require 3 or more sessions of lithotripsy to break the stone, to pulverize the stone. Now, ESW is not free from adverse effect. There are a lot of adverse effects. That is why this technique is not very popular. as far as CBD stones are concerned. Circuitous ecchymosis, bleeding complications, cholangitis, pancreatitis, sometimes bowel perforation, even lung perforation, splenic trauma, and cardiac arrhythmia. These side effects, when they happen, they are very severe. So this is not very popular method in most of the center, barring a few. Intraductal lithotripsy is catching up. Cholangioscope, it is different equipment. You can pass this equipment through the biopsy channel of the scope. You can directly peep into the CBD. You can pass laser fibers. You can pass electrohydrophilic equipments, and you can polarize the infected stones. And these are the trials. All of these trials on the criteria of selection were the number of patients should be more than 10. And you can see the results vary from 72% in earlier series to 90 to 100% success in the series which were published 2005 and onwards. Now, intraductal therapy versus conventional therapy. If conventional therapy is compared with intraductal therapy like cholangioscopic guided, then cholangioscopic guided techniques they are way better. But if conventional techniques are combined with biliary balloon sphincteroplasty, then results are almost similar. So we can, if we have to resort to these techniques only with when conventional therapy with biliary balloon dilatation fails, then we can go ahead with cholangioscopic guided techniques. Now, for difficult biliary stone, this is a comprehensive review of new and old lithotripsy technique. And last two columns which I have highlighted, they are important because these two studies pertain to utilization of these technique in failed conventional therapy using sphincterotomy and biliary balloon sphincteroplasty. So when after failed conventional method, cholangioscopic technique versus mechanical lithotripsy, you can see in both of these studies, cholangioscopic technique have better success rate than mechanical lithotripsy. 100% versus 63%, 93% versus 72%. So after failed conventional method, preference would be to go ahead with cholangioscopic technique available, especially after failed mechanical lithotripsy. So cholangioscopic techniques are very good. Now, failed stone extraction. We should also look outside CBD what is happening, like this and other causes. Like in this case, this is a pseudo calculus. This is not a true calculus. This filling defect is because of inspissated bile, which is stuck upon CBD wall, and this will give a filling defect. Whatever balloon sweep you do, you will not be able to remove it. Sometimes cystic duct stone overlaps with CBD and looks like that this is a CBD stone, difficult one. Whatever balloon sweep you do, this stone cannot be catch up. And if you rotate your C-arm, then you can see that this is a cystic duct rather than CBD. So this is also to be taken in. With failed extraction, this is one of my case. This lady had 2 ERCPs. Both time failed extraction. You can see a stent is there, which looks like very old stent. And when we did cholangiogram, it looks like that CBD is grossly dilated and there is large stone and narrow CBD down there. But if you look at this cholangiogram very carefully, you can see that the structure on left is cystic duct rather than CBD, and the stone is lying in cystic duct, which is very low cystic insertion. So this is a case of Mersey syndrome rather than CBD stone. So correct identification and correct high index of suspicion is needed because in these cases, the stone will not be removed with usual methods. And we should also be aware of unusual findings. Sometimes we just keep on focusing on CBD stone and we may miss something very important. Like this case, last week only I have done this case. This patient presented with obstructive jaundice of 20 days and mild pain. Cholangiogram revealed nothing remarkable. Complete cholangiogram, we did complete cholangiogram. Then upper part of CBD is not very well visualized. We did a small sphincterotomy, balloon sweep. We removed some of the stones, but we were not convinced with upper part of CBD because this is not filling up. Even when we put in a balloon and did occlusion cholangiogram, upper CBD didn't fill up. So probably there is a stricture. Then we took him for, in the same sitting, we took him for EUS. In EUS, we could see sludge in gallbladder, and you can see nice gallbladder neck with pharyngene cap-like of structure, but there is nothing there. And there was small round lymph node at porta. So if lymph node is oblong, then it is okay. Round lymph nodes are not good, as EUS data say. So we did FN up this lymph node, and it, to our surprise, it was adenocarcinoma. So probably this is a case of cholangiocarcinoma with CBD stone, and we should not miss these cases, and we should not sit quietly after removing the stone. Index suspicion should be. So these are my summary points. CBD stone, we do ERCP only if stone are seen on imaging, if there is cholangitis, or if there is high bilirubin more than 4, along with dilated CBD. These are the criteria, ANU, AG criteria. In other cases, we go for MRCP EUS to confirm the presence of CBD stone first, and then we intervene. For gallstone pancreatitis, ERCP, once pancreas cooled off, that is after 48 hours, we don't do ERCP in hot pancreas since it leads to complication and mortality. In cholangitis, we tend to do early ERCP within 48 hours. But if patient is very sick in septic shock, then we have to stabilize him first and then early cholangitis. Small stone, normal CBD, no problem. That will be removed simply with sphincterotomy. Large stone, normal CBD, sphincterotomy with balloon sphincteroplasty will serve the job. Large stone with narrow CBD, it is a problematic situation. We have to resort to mechanical lithotripsy, impacted stone, failed mechanical lithotripsy, spyglass cholangiography, endoscopic guided treatment. And with all these modality, this is the last algorithm I would leave you with. Need for surgery for the CBD stone per se, need has been reduced drastically, and most of the times stone can be removed with endoscopic.
Dr. Rajan, there are some questions which I have put in the chat box. You can maybe target those questions to individual panelists and seek the answer from them.
Before I go on to the questions, I have a few things to ask from Dr. Abhinav.
Yes,
sir.
please.
Abhinav, excellent presentation.
Thank you, sir. Thank you.
Illustrative and very informative.
Yes.
And from this, I got an inspiration to ask you a few questions.
Yes, sir. Yes, sir.
In 19...
Abhinav, it's flattering that
yes,
Dr. Rajan is getting inspiration from you.
Yes, sir. He has been inspiration for all of us, sir.
Yeah, please
go ahead, Dr. Rajan. At STPGI only, there was a CBD stone extraction attempted.
Yes, sir.
The Dornier basket got locked inside.
Yes, sir.
It could not be moved out, and
Yes,
Dr. Chaudhary was not willing to sacrifice the stone molding basket.
Yes, sir.
And then he was stuck, nothing to do. We were called in. We were operating in the OT. We were called in. What can be done in this situation? I said, just cut the wire.
Yes, sir.
And remove your scope.
Yes, sir.
He said, what will happen after that? I said, over to the first floor. We used to operate in the neurosurgical theatres, now present neurosurgical theatres. So very reluctantly he agreed. But that was an important thing to learn was that the stone with the wire or mesh on top of that was impacted in such a way that even at open CBD exploration, it was not easy to remove that.
Yes, sir.
Because it tends to get locked in somewhere and a bit of tissue comes in the wire. And then you have had it. You can't move the stone anyway.
Yes, sir.
That was one experience that was worth, and you demonstrated very rightly, strong mechanical lithotripsy to the wire can possibly solve the situation. At that time, these lithotripsies were not available.
Yes, sir.
Now, the second thing which I have to ask you is about the lithotripsy used on CBD stones.
Yes,
large stones being managed by ESWL particularly. The ESWL, do you have any information or are you aware of any study which gives a long-term follow-up of CBD treated by ESWL for large stones? There was a
studies are there. One of the studies from AIG only, Dr. Manu Tandon's study, I think in 1991 or 2011, I'm forgetting. But the long-term follow-up with the ESWL treated patient, there is high recurrence CBD stone. So that is the problem there.
No, recurrent CBD stone is not the issue. How does the CBD behave? I'll tell you the operative findings of patients who have been treated by ESWL when you go and operate on these patients, again, they were stuck stones. So when you open, the CBD is sputtered with multiple punctate hemorrhages.
Yes, sir. Inflammation, yeah, it leads to cholangitis and inflammation of CBD.
And
So-
what is next? On opening the CBD,
Yes, sir.
the entire mucosal cylinder of the CBD came out as a cast.
Yes, sir.
Now, this is a CBD which is bereft of mucosa.
Yes, sir.
We managed to close it, we put in a T tube, and after that, removed the T tube after 3 weeks. But I could not follow up this patient for more than 4 years.
Yes,
She
sir.
was not to follow up. Are you aware of any study which has looked selectively at the behavior of CBDs on long-term basis after ESWL?
So formation of stricture and all those complications will take very long time. I'm not aware that if somebody has followed them up for that long. And of late, people have stopped doing
Yes.
corporal lithotripsy because of these complications only.
No, these will be available only from older patients, 90s, 80s and 90s.
I'm not aware, sir.
Not aware. Okay. Good presentation. I must compliment you for that. Very informative lecture.
Thank you, sir. Thank you.
Yeah, Dr.
Now we
Rajan,
come on
please.
to the,
Yeah, the chat
points which have been
questions.
said. Monica Gupta's first question you've already answered. Stone size limit for ERCP, Abhinav has
Yeah,
answered.
but still, Monica's question, Abhinav, a direct question that
Yes, sir.
do you say no to endoscopic management based on the size of the stone?
Sir, 3 centimeter stone is very difficult one, particularly if it snugly fits CBD, because in these cases, usually even basket doesn't go across. Even if we are able to somehow manage a basket across, it will not open up, and all of the wires are not able to trap the basket, trap the stone. So these are the cases where straightway saying no is better than struggling in the ERCP. Because
But
once we put in the
what about lithotripsy?
Sir, if cholangioscopy guided lithotripsy is available, then it can be done. Mechanical lithotripsy is usually not successful in these cases.
So for the students, the answer is that if the stone is too big, and Dr. Abhinav says 3 centimeter, then if you have a cholangioscopic lithotripter, which will be a laser lithotripter, isn't it?
Yes, sir.
Yes.
Then you have an option. But mechanical lithotripter for a 3 centimeter stone would be no for most endoscopists.
Abhinav, there is one more question for you.
Yes, sir.
What is the incidence of CBD perforation following cholangioscopic laser lithotripsy?
Sir, cholangioscopy is very safe because the laser doesn't fire on soft tissue. So
Contact laser.
it's very safe. It's very safe. But yes, with mechanical, sometimes basket might go across. So mechanical is sometimes very dangerous. If there is lot of resistance, we should not pursue much, and we should not try to pass basket across it.
Yeah, Dr. Rajan, you can address the rest of the questions to the individual panelists, please.
Again, this is a question to Abhinav from Senegal. Impaction of a stone in the distal part of CBD. Some difficulties to remove the stone may expose to a spasm of the sphincter of body and probably a biliary fistula. Why? I'm not able to understand the question.
Biliary fistula.
Yeah, how will a biliary fistula form in this situation? It will not damage the CBD.
I don't understand the question, sir, exactly.
Yeah, even I can't understand. The second question was, do you think that a T-tube should be routine in this case? Which case?
I think Piyush can take that.
No, T-tube is not. Piyush can take that, yeah.
I think Dr. Guy Limbe wants to know that if there is an impacted stone, Piyush, would you take that?
I'm not able to understand the question.
He says that there is a stone impacted in the distal end of the CBD and there is a difficulty in removing the stone. So this may cause the spasm of the sphincter of Oddi. So even if you have cleared the CBD, in a case like this where you have done a lot of manipulation at the lower end, which may be inducing a spasm of the sphincter, would you then place a CBD T-tube rather than do a primary closure? I think that's what Dr. Guy Limbe wants to know.
I think, sir, if nowadays the recommendation is that if you are able to ensure and document that the CBD clearance is complete, then I think T-tube is not recommended. Most importantly, for putting in a T-tube, nowadays the T-tube has become so obsolete that you should have it before the procedure. Otherwise, you don't get a T-tube so easily nowadays, especially for those smaller size T-tubes.
Sir, stones in lower part of CBD is now usually not big. Usually these are small stones which get impacted in lower CBD, and usually we are able to manipulate wire across. So this situation, whether it's biliary spasm, sphincter body spasm is there or not, we can go ahead and cut the sphincter, do small sphincterotomy, and we can pass across his stent. And on second ERCP, I think this stone can be removed very easily.
So an impacted stone is not a problem for the endoscopist, because the moment they do the papillotomy on the stone gets exposed. It is a problem for us. So that is why if it is a small stone and it looks as if it is impacted at lower end, as Dr. Abhinav says, endoscopic is probably a better option. But Dr. Guy probably is hinting that at surgery, if we find an impacted stone, a lot of manipulation is done. So he is worried about the sphincter spasm. Yeah, we can take the next question then.
Yeah, can I come in between?
Yes, please.
Yeah. There are two important things about impacted stones. The nature of impaction just above the ampulla, very easy for the endoscopist to manage. Piyush showed, make a sphincterotomy and the stone pops out. Now, there is one situation where a chronic CBD stone forms a shelf in the lower CBD and impacts on that. That I have found endoscopists impossible to retrieve.
Agreed.
They are not able to negotiate beyond. And even at surgery, transcolidocal, we were trying to remove it and we were unable to do it. The last resort was cauterizing the duodenum, going behind and making a direct incision on the lower CBD and popping it out. It can be a very, very difficult situation, even at open surgery. If there is a shelf forming there, long-standing impaction of CBD stone, it can be a hell for the surgeon and the endoscopist both.
No, but Abhinav, Abhinav, suppose there is a stone impacted at the lower end. You can't pass a guide wire along with it because it is tightly fitting, but you can always open the papilla on the stone.
Yes, sir. Yeah, that actually I showed in the.
You showed that picture also.
Yeah.
So that is the point I was saying, that for an expert endoscopist, an impacted stone should not be a problem.
And I think, sir, nowadays
we didn't touch on that. Piyush, would you say that today, with all these expert endoscopists around, is there any place of a transduodenal sphincteroplasty to take out an impacted stone?
I don't think so, sir. I was amazed to see a slide, sir, where there was not even a single indication for surgery for CBD stones less than 3 centimeter.
Oh, okay. Hold on. I'll come on to that. But before that, I want to make a comment on Piyush. Piyush,
Yes,
your
sir.
statement about T-tube becoming obsolete.
Yes, sir.
I would advise you to refrain from using these terms. Surgical literature has a lot of lessons to learn from if you have read the past. How things have evolved and come to a present stage. What is difficult today to get is number 10 T-tube. Most
Yes.
people don't stock it. So if it's a normal size CBD that you're dealing with, then possibly you will be in trouble in trying to secure it. And then the best way out there is put a double pigtail stent.
Yes, sir.
And throw the CBD over
I
that.
agree.
Right?
Yeah, I agree that a stent is a better option.
It's a better
Because
option. In a thin
T-tubes
wall,
are-
small size CBD, that's a better option to use.
Definitely, sir.
And you have to make sure that the stent has gone across the papilla into the duodenum. Yeah, Abhinav, please explain this.
So this is the case, sir. Biliary acute pancreatitis. We can see on the first panel, left upper corner. You can see bulging papilla. This is typical appearance when stone is right at the orifice, because of constant bile flow and pancreatic juice flow, the papilla swells up and it bulges into the lumen of the duodenum. We just need to put in a nick over the mucosa and sphincter orifice, and stone pops out. This is the situation one. The second situation which Dr. Rajan is referring to is stone impacted not at the papilla, but in the lower CBD, just within 1 to 2 centimeter papilla, forming a small diverticulum there. That is a very difficult situation for even endoscopists, because balloon and basket slips out. In lower CBD, we need some space for cholangioscope to insert. So that is a very difficult situation.
So this question number 5, Vinay Timilsina, that what is the management of impacted distal CBD stone despite 2 or 3 RCP sessions? I think that would be a very, very rare situation today, isn't it?
Yes, sir. Yes, sir.
Vinay, this other question we are going to handle tomorrow when we are going to discuss the CBD drainage procedure. So I think I will leave it at that. I had a question to Abhinav, and then Piyush can also answer that. That you have gallstones and CBD stones. We have decided for a pre-operative ERCP, endoscopic clearance, and followed by lab chole. You have documented that CBD is clear. Would you leave a stent or would you not leave a stent?
If ERC, that depends on multiple factors. Sir. Number one, where patient is coming from and where patient will go for is lab chole. Suppose he is going outstation, मैं अपने native place में lab chole कराऊंगा. In that case, we'll always put in a stent. If cystic duct is very wide on endoscopy, and indirectly we can also assess by the number of stone and the size of stone. If multiple small stones are filling up the CBD, then probably cystic duct is wide. I would like to put in a stent. But if it is a very small stone, single stone, narrow cystic duct, the lab chole is being planned in the same city on the very next date, then I would not put in a stent.
Piyush, as a surgeon,
Yes, sir. I like to make a comment.
sorry. As
Yes,
a
sir.
surgeon, if the endoscopist has cleared the CBD and you are going to operate the same day or next day, would you prefer to have a stent or would you not like to have a stent?
Yes, sir. I like to make a comment. This is always a debate we are going on between us and our gastroenterologist. As already told by sir that they are not in favor of putting in a stent. But as a surgeon, I would like to have a stent placed because even if we do within 12 hours or within 24 hours, there is a lot of inflammation in the porta and around the Calais triangle. So it is always safe to have a stent inside the CBD when we are dissecting around that area, and we can easily clip the cystic duct because we have a stent in situ, and also it helps in easier identification. So I think it is, as a surgeon, I would like to have a stent placed because removal of a stent just hardly takes an endoscope to remove after 4 to 6 weeks.
But I would caution the students that if you are doing a lab chole in a patient who has a stent in situ, for patient's sake, please tell the patient, tell the relatives, make sure get an appointment with your gastroenterologist to get the stent removed. And for your own sake, please document in the discharge summary advised stent removal. All of us have seen stents lying in the CBD for months and sometimes even years, and that would amount to negligence. So for patient's sake, as well as for your sake, tell the patient and document it.
Vinay, I have removed a stent today after 19 years.
We also have Dr. Iqbal Salim, who's going to join us tomorrow. But Dr. Iqbal, we would love to have any comments from you. Monica is also there. Monica, please feel free to chip in. Saurabh, are you there? Saurabh Galoda? Saurabh had sent a comment that he had done some study on pre-op ERCP.
Yes, sir.
Yeah, please. So Saurabh, can you give a brief summary of the study which you were referring to on the chat? Please come in.
Yes, sir.
So Saurabh again is a former fellow from SGPGI. He is currently at AIIMS New Delhi. Yes, Saurabh.
Sir, actually, when I was in Himachal, that is about 2-3 years back, we had given a study to one of our PG there. Where actually we did a sequential ERCP. That is because the ERCP was actually being done in the same OT that we used to do, like another OT. So what we used to do is we used to do in those patients, we selected the patients in which we were sure that the clearance was done. So we included 63 patients and we had 3 groups. One group was in which a sequential ERCP was done. That is within the first 6 hours we used to do, like after they have done an ERCP and patient is out there and there is a complete clearance of stones. So we did a lab chole in those patients after this. And second patients were in which within 72 hours we used to do a laparoscopic cholecystectomy. And the third was the classical one where actually we used to wait for 6 weeks post ERCP to do a lap cholecystectomy. And we found that if we are able to, so the problem with the sequential ERCP, which was the most common, was that there will be a lot of bowel distension. Because obviously you are using some amount of gas also, and so distension of the bowel. And so actually we faced in the total 21 patients each. Out of this, in group B, where we were actually doing 72 hours, within 72 hours, 2 patients developed pancreatitis. So they shifted to the delayed phase, that is after 6 weeks. But when we compared as parameters, we compared was operative time, bleeding, bile, and then finally hospital stay. And we found that the sequential ERCP has the only issue that if we were able to, like initial patients, we had this problem of abdominal distension, the bowel distension, how we had to cope with it. But then we found that we talked to our ERCP guys, friends, and they would do suction, and we were able to do the surgery in all patients. 3 patients we converted to open, but out of those, only one was due to bowel distension, while 2 were actually because of uh, uh, clear Callet's anatomy at that point in time. So total, if we compared the least among, and even the hospital stay was also least in the sequential ERCP. The good point for us was that because we were doing in the same OT suite, so we did not have a problem of shifting the patient to some other place and all that. So that was an advantage to us. Probably that is one of the reasons why we did not have the logistical issues that usually we face with the sequential ERCP. But we found that if we are able to do in the same sitting after the ERCP, we can do a pre-op ERCP and then follow it up with a lap cholecystectomy. Need not wait for even for 24 to 48 hours that we usually.
Yeah, so basic issue is the logistics.
The issues that to cover those logistics, we found that we actually presented it last year in the ACS annual congress in Boston. One of the MBBS fellows presented it. I didn't go, but somebody else went and presented it, and it was very well received actually there. And they said that yes, it is because actually there were also many centers there also are following the sequential ERCP.
So another question I would like Piyush to
That
answer,
was-
and then Dr. Rajan to comment that when do you operate after the CBD has been cleared endoscopically? Same day, next day, or wait? Piyush first, and then Dr. Rajan's comment.
Yes, sir. So before I think answering this question, I'd like to make a comment upon Saurabh sir's. I think what I already discussed or showed in my slides also that best is the intraoperative ERCP. So, like if we do simultaneously with lab chole, when the cystic duct is cannulated and we have the access to the CBD, so there is no problem in dissecting the callets after the bowel distension. So then it is easier and technical success is also more that has been shown. Regarding the question, sir, I think as far as we practice, because of our logistical issue, and at least we wait for almost 18 to 24 hours after having an ERCP.
So which means the next day.
Next day. Because it gives a
Suppose logistics are not an issue. Scientifically speaking, would you do it the same day or the next day?
So I would like to wait for at least 12 hours because it gives.
Tell the reason for the students.
Yes, sir. So waiting gives an idea whether the ERCP procedure was smooth, patient has not developed any complications related to that procedure that may affect your another procedure. So waiting for 12 to 24 hours is a safer option. And also the bowel distension caused by ERCP will settle down in that period. So doing a laparoscopic surgery will also become easier in a gap of such period, sir.
Dr. Rajan, your comment on this?
2 comments, Vinay. If you do the surgery within the 24 hours period after ERCP, these patients resume oral feeding much later. They are not comfortable after laparoscopic cholecystectomy the way a normal patient is. And this is my observation. I have actually now taken on a policy. I would not do cholecystectomy on the same day or the next day. I wait for 48 hours. I have seen 2 cases of pancreatitis manifesting 24 hours later. The amylase was elevated, but clinically the patient was fine. And 24 hours later, the patient was miserable. So problem of ERCP, most would manifest on the same day. Right? But there are some who would manifest later. And then you are in a conundrum after that.
So
what
Abhinav,
is a physical problem or it's an ERCP problem, it's very difficult to determine that.
Abhinav, as an endoscopist, can you predict which patients are likely or more likely to develop post-ERC and acute pancreatitis so that we can take more precaution? Maybe we can wait a little longer, as Dr. Rajan is saying.
Yeah. So young patient, repeated pancreatic ductal cannulation, pancreatic contrast injection, what we call arborization or acinerization of contrast is very high predictive value that patient will land up with pancreatitis. Then need for hemostasis at papilla, which where we use coagulation, that these patients can lead to pancreatitis. So multiple, time taken to cannulate. Recent is that even if you don't cannulate pancreatic duct, but if you spend more time on papilla, simply feeding with papilla leads to increased risk of pancreatitis.
So although most of our audience is surgical, but I think surgical students should know what are the methods you use to prevent post-ERCP pancreatitis.
So the problem with post-ERCP pancreatitis is that even after this parameters, suppose patient is not young and we have not fiddled with the papilla much, still pancreatitis may happen. It is totally unpredictable. It is kind of anaphylactic kind of reaction. But to mitigate that, if the risk factors are there, like previous biliary pancreatitis, earlier we used to do sphincter Oddi manometry where pancreatitis rate was to the tune of 30-35%. Or if young patient is there, or if cannulation takes longer time, if we have put in a contrast, multiple guide wire to pancreatic duct, then the protocol is hydration. Then we can give rectal endomethacin, drain out whatever contrast is gone into PD and put in a pancreatic stent. These are the measures which we can utilize to reduce risk of pancreatitis. But I'm saying it again, these methods are not foolproof. Still pancreatitis might be there. So these are the cases where I think we should wait for at least 24 to 48 hours before embarking upon that policy.
Professor Kapoor.
Yeah, please, Dr. Iqbal.
Good evening, sir. So first of all, congratulations for this wonderful initiative. It's really going to be helpful to the students. Now I have got two questions for Abhinav. I hope you won't mind. The first is that in the recent times, we have had two cases where the basket was impacted. Do you feel that the quality of the baskets is deteriorating on day-to-day basis? Because it did not happen for the last 10 years and suddenly two cases. And it's very tough cutting this basket. We had to use those very heavy scissors. We took them out through the port and then we cut the basket. Very tough. Yeah. What do you feel about the baskets? Are they deteriorating?
Scissors are not recommended to cut the basket. You should have wire cutter, and that to a newer one in your endoscopy room, because these wires cannot be cut using scissors.
It's so not those scissors that we normally use. So no. Yeah. The heavy ones, we had to get the biggest possible scissor, and then we could cut them. It was not possible otherwise, because it had never happened.
Yeah.
So do you feel the baskets are deteriorating in quality?
Yeah, yes. So local baskets from local companies, they are not up to the mark. Two problems there. Ideally, basket, all four wires, they have bulbous tip, and basket should break from that tip. Suppose if you get infected, and suppose if you are doing lithotripsy, if stone is too hard, if it is not breaking up, then at least basket should break and all those four wires should open up. But if that tip, solder tip, is very not of good quality, then basket will not break and basket will get infected. So off late the cheaper basket which are coming up in the market, the problem with those baskets are they get deformed very easily.
Definitely.
Even with first ERCP, they will get deformed and they have unpredictable breakage. Sometimes the basket remains intact, the wire breaks down. And if the basket is hanging in the CBD, you don't have any access to the basket. Also, patient lands up with surgery. So yes.
My second question is, have you any experience of doing ERCP in patients of situs inversus?
No, not yet. But
we have had two cases, and in both the cases, unfortunately, our endoscopists, they could not cannulate because of the turns, and believe me, it was very difficult operating those patients. But definitely, it's something that we have to keep in mind once we are going.
And only such case was being demonstrated in AIG Endocon last week only. And operator who is a very skilled one had difficulty. One of the trick which I was discussing with senior people like Dr.
You lost his audio.
Yeah. So one of the trick is you do it in right lateral position rather than left lateral position. That is the trick which is suggested for situs inversus.
Thank you very much.
Abhinav, can I come in here?
Yes, sir. Yes, sir.
One more trick which I heard from an endoscopist in Milwaukee. He has some experience of doing on 2 or 3 cases, situs inversus cases. He
Yes,
says,
sir.
I don't use the side viewing scope is there.
Yes, sir.
He prefers to go with a straight viewing scope to get to the papilla in patients with situs inversus. The anatomy is just the reverse.
Straight wing is straight with endoscope doesn't have elevator. So therapeutic options they
He
get.
could do it without the elevator because it was such a direct access.
Yes, sir.
He said, I waited with the side viewing scope and I tried, and then when he failed, then he got an idea, let me try it with this one.
Yes, sir.
And he
So
could manage it straight away.
Yes, sir. Good tip. I will try in next week.
Just remember it, if ever you are in trouble, try it out.
Yes, sir. Yes, sir. Yes, sir.
The second thing too,
Right.
Dr. Why scissors are not recommended both at the same time?
Yes, sir. Yes, sir.
That is the reason why wire cutters are recommended.
So Abhinav,
Professor
Yes, okay,
Rajan.
Yes, yes.
Yep.
Professor Rajan, basically, it was a first time experience with us. We had a patient with a wire coming out and through the mouth, and it was quite difficult for the patient to be
Panic
in fact, we
situation.
shifted next day, and then he pulled it out through the port, and then we were at a loss. How do we cut this? Then we got those big scissors, which we use for cutting. I mean, gauze and everything. That was the only thing we had available.
Well,
That
I tell
it was a
you,
new experience.
if you have a CBDS OT next to you somewhere or an orthopedics OT, just ask them for a wire cutter and that's it. Don't
I
even
hope
look
we
for-
never face it. I hope we never face it
No.
again.
You should always be armed with one experience. It is always wise to be secure about this thing. It's a very inexpensive instrument. But
True,
it's
sir. True, sir.
Abhinav, one more question. Would you recommend that after an endoscopic intervention for CBD stones or for any other indication, should we do a serum amylase lipase as a routine the next morning or only in selected cases?
So routinely amylase lipase will always be elevated if we fiddle with papilla. So that is not pancreatitis. Even if it is 1,000, it is not pancreatitis. Pancreatitis is a clinical syndrome which happens after ERCP only if symptoms are there. So we have to go for symptoms rather than amylase lipase values.
That's very important for the students that surgical students, the moment the patient comes back from the endoscopy suite, you have to ask the patient whether the patient has any undue pain. You have to examine the abdomen and you have to re-examine the abdomen the next morning also before you take the patient to theater, because the consultant is going to come to the theater when the reports have been put in. It is your responsibility to examine the patient the morning before the patient is taken to theater. If there is any doubt, if the patient is having undue pain, is having nausea, is having any abdominal signs, please get, as Dr. Abhinav says, serum amylase lipase done. Tell your consultant that we should reevaluate this patient. Maybe, as Dr. Rajan suggested, don't do the lab chole even the next day. Wait for another day. Make sure that there is no post-ERC pancreatitis, because if this patient is having post-ERC pancreatitis, after lab chole, it will be very difficult for you to know whether the unsettled patient is because of pancreatitis or because of a bile leak and bile duct injury and bile leak. So this is very, very important. And second thing I already pointed out is the instruction, verbal as well as written, for removal of stent. So any other panelists would like to make any comment? Otherwise, then I will...
Vinay, just a
yes,
question
please.
to Abhinav.
Yes, please. We
Abhinav.
have 3 minutes.
Hello, Abhinav.
Yes, sir, listening.
यार एक सवाल का जवाब दो. ये
Yes, sir.
पेशेंट जिनको ERCP के बाद पैंक्रेटाइटिस होती है, it's an observation that they have an exceptional high grade of nausea following ERCP, which I don't see in other patients. Is it correct?
Yes, sir. Yes, sir.
Right.
They have some kind of uneasiness, restlessness in the abdomen, which they think that if they vomit, they will ease it out. But that doesn't happen.
Doesn't happen.
So I have a question. Like,
Yeah, Piyush, please go ahead.
if for whatever reason CBD clearance is not possible, or you have just put in a stent, so what will be the minimum time period for after which a second endoscopic should be attempted?
Yes, very important.
Minimum 4 to 6 weeks.
Okay.
Because stent moves up and down CBD with the duodenal peristalsis. So this friction softens the stone and sometimes breaks it up. So, 4 to 6 weeks is required for that mechanism to happen.
And during this 4 to 6 weeks, sir, is there any role of putting a patient on UDCA?
Yeah, there is a study of stent plus UDCA also, and it tends to favor UDCA plus stent.
So I would like to thank Dr. Rajan. And Dr. Rajan, we hope to see you in both Jaipur Surgical Tutorial and Master Classes, because you have served a long innings at SCPGI. Now you have moved out of SCPGI, but I think the teaching itch we all have, you still would continue to do that. So we would hope to see you again. And I would like to thank the three speakers, Mohammad Yunus, Piyush and Abhinav, and I also thank Dr. Iqbal and Monica for joining, although they would be joining us tomorrow again as panelists. So thank you all very much, and I would like to thank the IT team of Dr. Avinash Tank. Manshi is the foundation, she's the strong foundation of all the online educational activities. She does all the recording, all the uploading of the videos on the YouTube and on the Gastro University channel. So thank you very much, Himanshi and Avinash. Thank you all. Thank you very much.